coil occlusion of the PDA, and essentially it's a bit of a quiz, but not so much as in the last session that we did on catheterization hardware. This one we will have, because I don't know if everybody is that familiar with this procedure, so we'll probably do it with a little bit of both, a little bit of didactic discussions and also some questions and answers based on what we have shown you. So there is still a role for PDA coil closure today, and I think we've tended to move away from it a little bit more than we should have. I think it's still a very good procedure. It has a fair amount of scope, and it does produce an equally good result if you select your cases well at a much lower cost. So today's talk is on what is the role of coil occlusion of PDA, and this has changed maybe over the last 8 years since we started doing it here in Amrita, and the significance of case selection, which is really important, the technique, which I think people have to learn, and there is a lot of hesitation there, and of course the results. So why use coils when it's a no-brainer to put an occlusive device? I mean, you can put a device into anything. So I think why is it that we should go and walk the difficult path of trying to put coils? The most important reason in our country is it's very much inexpensive in comparison to the device. So costs matter to the patients, and if you get an equally good result, then I think it's worth offering that. Second, of course, in small infants, it's a better alternative to conventional duct occluders because there is a potential for aortic narrowing, and with ADO2 there is a potential for branch PA narrowing. So I think for those two reasons, in small infants, I think PDA coil occlusion is still a very good option. And in preterms, it is the only option, and we'll discuss preterms in a little greater detail here today. So if you look at this picture, this is a child who underwent closure with an ADO1, the classic ampulla duct occluder, and you can see that the aortic retention disc has found its way into the isthmus and produced isthmic narrowing, and these are pretty much evident on the echo pictures very nicely, and you can see the flow acceleration that results. Now there is a theory that this aorta will grow with time and these patients will get better, but it doesn't always happen. And there have been instances where we've had to deal with the coarctation that has followed. So it's not such a straightforward task to put a small device into small children. And so who is the candidate? The most important thing about the coil is, unlike the device, it needs an ampulla to house the coils. The coils have to sit inside the ampulla, and that's the most important thing, that you need an adequate ampulla. And I put adequate within quotes because adequacy will depend on the size of the coil. The larger the coil, you need a larger ampulla. The size of the coil is at least twice the narrowest segment of the narrowest diameter of the PDA. Okay, so if you look at this picture, this is a cartoon that shows an ampulla, the aorta, the branch pulmonary arteries, and the narrowest end that is indicated by the two relatively short arrows. So the principle of coil occlusion is you put anything there in the ampulla that is large enough to not embolize into the PA, but small enough to fit right inside the ampulla. You can put anything and it would stay there because the aortic pressure would keep it there. So the most important thing is that this coil mass should not jet out into the aorta. Then the flow in the aorta will push it out. So if you have something that goes inside, but it's large enough that it doesn't come out, then it would work. So that's the essential principle of coil occlusion. It's different from device. In device, you're stenting the duct at the narrowest portion. So that stent will essentially is the mechanism that holds the device in place. Fundamentally different mechanisms. So it's very important to have a retention disc, and in this case the retention disc is rather ideally positioned, but often it sits inside the aorta. It's very difficult to actually prevent that from happening. So this, however, if the ampulla is small and the duct is large, there isn't a better option than the device. But here, if your ampulla is adequate, the duct is relatively small, the patient is small, and you don't want anything sticking out, then coil is a better option. So if you can actually pretty much figure this out by echo and plan the procedure in the echo room, you don't really need to take the patient to the cath lab, do the angiogram, and then decide. The echo produces very good images, and you can actually see all these structures. You can define the ampulla. You can see in this particular case that the ampulla is adequate. You can easily visualize a coil twice the diameter of this narrow segment sitting in out here. You can also see a very interesting phenomenon on color, that the descending aortic Doppler is actually towards, this is a diastolic frame, and you can see that entire flow is backwards, which means that if you actually have a coil mass in the proximal descending aorta, it would get naturally pushed into the ampulla. So that's an important principle that you sort of use when you try to coil ducts. Now this is a zoomed up image that measures the narrowest segment, and that is done in black and white and not in color, because color can actually distort that picture. So if you get these three images, you pretty much can decide who is suitable for coil, who needs devices. And this you can get in almost any infant. You don't need to catheterize. And this, I think, has not permeated the consciousness of interventionists. Mostly everybody feels that it's necessary to do an angiogram. It's actually much better, much more accurate to measure the PDA in its narrowest segment using echo if you have good images. And if you can see this picture, it actually compares echo pictures with an angiographic picture and shows you equivalent images, same patient. And you can see that this angiogram is essentially a replica of what you see in the echo. And you can almost decide by this echo that the ampulla is pretty generous. There is large, but it's not terribly large, so you can easily visualize a coil twice the size of the narrowest segment sitting within this ampulla and occluding the duct without sticking out either into the PA or into the aorta. Ampulla comes in different shapes and sizes. I know that there is a classification, and I'm sort of reluctant to use this classification because I think there are so many categories that don't fit into either of these classifications. So it's important to recognize them as they are, and rather than give them alphabet or a number. So here are several examples of ducts which can be of varying. The ampulla can be of varying sizes. It can pretty much be non-existent, or it can be very long and tubular. And very rarely you have the situation where the aortic end is narrower than the pulmonary end. And this is relatively difficult with any technique, of course, unless if you have a patient is relatively large and you can actually put in a ADO2, and that should be all right. Otherwise, in general, these are the various types of ducts that come in various sizes and shapes of the ampulla that again lets you decide as to what you can do for the patient. So we'll have a little quiz here now. So I'm going to put various images of angiograms, and I'm going to ask, I'm opening up the chat box, and I'm going to ask people, well, look at participants, I think, yeah. And I'm going to ask for people who, what their opinion is. So what would your choice for occluding A would be? What would you use in this particular case? Can somebody take a guess? Am I able to see everybody here? Yeah. So what do you want to do here? A. Ashish, aage. What's your choice for A? Am I able to see everybody's? Yeah. Okay. ADO1. So that's yes, I agree. And what about B? Let's look at B. So B, again, I think B says coil, but actually, to be honest, it's also a shallow ampulla, and you need to do ADO1. ADO2 is fine, but you know why do ADO2? This patient, it's going to be an additional cost for nothing at all. This is a big, lots of space. You can easily put, you can imagine the retention disc of the ADO1 sitting in here, and you can put any size, pretty much a fairly large ADO1. In this particular case, you can actually put an 8.6 and this will close. This one, of course, C is ideally suited for. What about C? C would work with, you can use an ADO1, but you can see that the duct is quite narrow out here. The narrowest point is where the catheter crosses, and it's really narrow, and it's an overkill to put an ADO1. You can actually put a coil in this particular case. ADO2 is very expensive. Why would you like to subject a patient to that much of expense when you can actually occlude this with a coil? And that's what we will discuss as techniques today. As to how this, I would never put in an ADO1 or 2 in this patient. I would use coils, and with MRI coils, you have MRI compatibility, and really you would save a lot of expense and you would have an excellent result. So I'm going to then pull out and actually show you D. So what's your choice for D? So C would be coil. People would use ADO1, but my preference is coil. There's a lot of love for ADO2 after it's come in, but you have to recognize it's costing 50,000 to the patient. This is not tubular. Actually, no. This is fairly decent ampulla. This is not a tubular duct, and what you're seeing here is a jet coming out of the duct into the PA. So it is actually not tubular. Tubular is down below. I'm talking about D, and here, of course, coil. Multiple coils with a biofilm, or an ADO1 if you're not comfortable technically. For that reason, so D would be coil. E is a clear case for coil. I agree. So F, anybody can put a coil in F. So it's very straightforward. You have a huge ampulla, and actually very easy to do coils in F. G also is the same case. You have an excellent ampulla, and it's really very easy to close it with a coil. Now the real test is in H. How are you going to close H? The last very long tubular duct from here to here, and this is a very big challenge. Now let's discuss this one in particular because this is challenging. How do you want to do this? Can I hear somebody says ADO2, but recognize this is a small child. Now if you put an ADO2, you have to have one retention disc sit here and one retention disc sit here. So there is potential for occlusion of both aorta and the pulmonary artery. There is potential. You can get away with it, but you have to try. AVP2 is the answer really. I agree with you, and the answer really is AVP. You can try an ADO1, but AVP is a much better choice. Ampulla is a vascular plug. If you can get a big enough plug to sit inside, which is minimum twice the diameter of the PDA, then I think you can actually get this to be closed. So I think that's how you would approach these ducts. It's very individual. It's dependent on shapes. It's dependent on adequacy of ampulla. It's dependent on size. It's dependent on aortic diameter. So there are a number of variables. They look complex, but it's not difficult once you understand the principles as to how the ducts get closed. The device stents the duct, and the coil sits inside the ampulla. ADO2 works through the principle of the fact that you have two discs that move towards each other, and that will keep the device in place. So these are all the principles for doing device closure. So that's essentially, I think you've got the hang of how you decide what is to be done in these patients. So we'll now focus a little bit on the technique of coils, how to do it. So what are the techniques available for coil occlusion? So there are, I have classified this, and we can look at the techniques, and there are essentially two ways of doing it. One is the uncontrolled way. Well, antegrade and retrograde is excellent. I have almost abandoned the antegrade approach, retrograde approach via the aorta for two simple reasons. I don't want to puncture the artery of a child if I can avoid it. So I don't puncture, I don't get arterial access in any PDAs that we do here. So that's, and I'll show you that you can actually pretty much do an excellent job without having to puncture the artery. So that's the reason why the retrograde approach has been mostly abandoned. And the antegrade approach is far superior because you can actually take advantage and deliver the coil in a much more controlled fashion. Now, the techniques that are classified as essentially pre-coil delivery and assisted delivery. Now everybody, I think people are becoming incredibly more nervous with pre-coil delivery as they have lost touch with the procedure. It's not that difficult, and we'll show you a little bit about that. Assisted delivery can be with biofilm, with using detachable coils, which are very expensive, so we've also stopped doing that, which comes with a cooked detachable coil system, and of course the snare assisted device that we don't use anymore. So this is how you do it, and I'll be talking about little bit about pre-coil delivery and biofilm assisted delivery. Biofilm can be single or multiple, and we've pretty much started to use biofilm only with multiple coils. And this technique is what we have developed here, and we'll talk a little bit about that. So this is how not to do pre-coil delivery. And this is why people are nervous about it. That's absolutely the wrong way of doing it. As we've recorded the sequence to show you that this is not how it should be done, I'll show you the sequence as to how it should be done. So what went wrong here was that essentially the coil was pushed out of the catheter. You shouldn't do that. You should cross the duct. As you can see, the tracheal landmark is important. The arrow points to the narrowest part of the duct, and you can relate that narrowest part with the tracheal landmark. The ampulla is profiled by a simple injection in the distal aorta. The duct is small, as indicated by the fact that there is no flow possible once the catheter is across it. So this is a tiny duct, and therefore pre-coil delivery is only for the small ducts. Important to recognize how much of your coil remains inside the catheter. That is your clue to how safe you can do the procedure, not how much comes out. So keep a track on the junction between the guide wire tip and the length of the coil remaining in the catheter, vis-a-vis the tracheal landmark. You know your landmark. So the anterior border of the trachea is where you have to be. You have to visualize your coil sitting in front of the trachea. This is the lateral view that we are seeing. And then go stepwise, go very slowly, release the coils, come inside the ampulla. Once you are in the ampulla, the coil stops oscillating. It gets trapped in the ampulla. At that point, you can slowly, don't push your catheter. Never do that. Never push your coil out. You just keep your coil there and withdraw back your catheter. The catheter comes back and the coil then turns, and you have a small turn remaining in the pulmonary artery, not because it helps in stability of the coil, but it ensures that the coil is adequately within the ampulla. And you can remember that the trachea here in this particular case shows you where the ampulla is, and you can see the coil sitting very much within the same landmark. So this is a simple pre-coil delivery. People are afraid to do it, but it isn't that challenging. If you are with very little practice, you can be very good at it. The important thing is to do it slowly, release a few turns, gradually pull back your catheter, and imagine the cost is ridiculously low. You have a small duct which you sometimes want to close. You can do it all within 5 minutes with a single catheter, a single coil, and a single guide wire without an arterial access. You save an incredible amount of money for the patient, and with expertise you don't really endanger or run into the risk of embolization. So this is the technique that we have developed, and I'm going to talk a little bit about this technique that we have actually shown. We're showing you photographs of it. In this particular case, this was a patient with a large duct. We had 4 coils. These are the steel tubes which house these coils, and we pushed out half a turn each of all these coils from these steel tubes. Then we take each coil and stretch it with the artery forceps till we have a small amount of length of stretched coil that will allow us to tie them together with a 3-0 proline. We tie it with 3-0 proline. Remember, the most important thing is not to let the coils come out of these steel housing that keeps them, so that allows very easy preparation of the coil, composite coil. So once you've got that, you take a biofilm. This is a 5 French biofilm. This is not a 5 French. I think this was this is a 5 French biofilm, and this is probably a 7 or 8 French sheath. We pass the biofilm through the sheath, open the jaws of the biofilm, grab this coil mass, and then pull it right inside the sheath, and they're all together in this particular picture. We pull it right inside. Then we take this entire sheath, this is just like your device, and take the sheath and put it behind into the venous, the valve, the check flow valve of the long sheath that is being placed across the duct. And then this entire coil mass can move as one unit. So that's the essence of how we do the biofilm assisted multiple coil delivery, which has allowed us to do an incredibly large number of duct seals. So what do you require as hardware requirements for the biofilm assisted technique? There is a number of things. The one thing I keep teaching and doing in the cath lab is that before I do a procedure, I always list the hardware that I anticipate to the technician. That I think allows a much more expeditious use of performance of the procedure. So I think we need to think about the catheters and what catheter would you start with in multiple or any coil occlusion. You need to have some catheter plan. What will you tell your technician? Can anybody answer that? So multi-purpose RCA guiding? No, not really. Multi-purpose is what your initial role is not to put. You're not going to deliver the coil. We're going to cross the duct. So multi-purpose is my preferred coil. Actually, not RCA. You know, the RCA has a bend at its tip. So when you're crossing the duct antegrade, your catheter should be as straight as possible in the MPA so that it hits and faces the roof. The RCA has a bend that faces the branch PAs. So in the RCA, it becomes actually relatively difficult to cross the duct. With a multi-purpose, your chances of crossing the duct is excellent. So that's the items that you would prefer. The wires to cross the duct, the best wire is, what's the best wire to cross the duct antegrade? Not thermo. If it is thermo, then you should use a straight tip thermo, but the ideal catheter is a straight tip Teflon, this usual simple guide wire that you use for most of your procedures. Important thing, it should not be J, it should be straight tip. That way it just goes straight to the roof of the MPA and crosses it every single time. So if you have a difficulty in crossing the duct antegrade, remember this combination of multi-purpose and straight tip Teflon guide wire, it will cross. Okay. Next, coil, of course, we will talk about that. And I don't expect you should have coils of twice the diameter of the narrowest part, but we have some formulae that we will discuss and share with you. Biofilm, if you're using a 5 French biofilm, essentially is for older patients. The 3 French is for younger babies. Both these biofilms can be reused, but the 5 French has much better reusability than a 3 French. A long introducer sheath, and we'll talk to you about the long introducer sheath as to what diameters work for which coils, and that is the slightly difficult part to figure out, but it's not a big issue once you started to do a few procedures. Always have retrieval systems whenever you do any procedures. So a snare catheter, 10 mm snare is what you would use for most retrievals, and sometimes a 5 mm snare needs to be available. So I think you need to have your planning of hardware on these lines: catheters, wires, coils, biofilm, introducer sheath, and retrieval system. So this is a table I've taken from a chapter I've written on PDA coil closure, but I'll just go through it. It's a little busy, but you need to just figure out that the coils are available in 038 inch and 052 inch, and 038 is at 4 mm, 5 mm, 6 mm, and 8 mm diameter. There is 10 mm, but pretty much you don't need to use it. 052, in the era that we didn't have devices, I used to use the 052 very extensively. So you have even 5, 6, 8, 10, 12, 15, but really 12 and 15 you seldom use. So these are 052 coils. The important thing to recognize is that 052 is not MRI compatible. Only 038 comes as MRI compatible and MRI non-compatible. MRI is called MREYE, and this is what we use almost exclusively for coil occlusions now. We don't use the 052 coils unless the patient is unable to afford a device. The smaller ducts are the ones where you use the 038 coils. You need the 052 for the larger ducts. The Jackson detachable coils with delivery wire is a Cook detachable sheath. We don't use it here, it's very expensive, but there are operators who prefer this. The multi-purpose catheter, of course, I told you about the straight tip Teflon coated wire to cross the duct for free coil delivery, or even otherwise. The glide wire is when you have to recross the duct for additional coil delivery. That is the Terumo wire. The right coronary catheter, JR4, is for delivering additional coils. You need to have these hardwares. We use the Balkan contralateral sheath, which is basically a sheath that is meant for adults from one groin to the other groin, but it works beautifully for infants with duct. But the Mullins is used for the older children. Biofilms, I told you about 3 French and 5 French. The gooseneck snares are the Amplas gooseneck 5 mm and 10 mm snare for coil retrieval. Rarely we need the vascular retrieval forceps. You don't often need it. But these are the hardware that you need to stock in your lab before you start doing coil occlusions. So this is the thing that everybody wants to know. What coil combination for what? And there is variability. I'm just giving you some suggestions here. You may change this depending on your own assessment. And as I said, we are almost exclusively using the MRI coils, which are MR compatible. And these are 2.5 to 3 mm ducts. We use less than 2.5 you can actually do a free coil delivery, but 2.5 to 3 mm, 2 coils, 5 mm and 6 mm, 3 to 3.5, 2 coils, 8 mm, 3.5 to 4, we use 3 coils, beg your pardon, I'm sorry about that, 3 coils, and so on. And then I've listed all this. Beyond 4, we have almost stopped doing coil occlusions and we've switched over to devices because they are all MR compatible. And the cost advantage is there with coils. If somebody is really desperate, we can use coils, but we pretty much would like to do them with devices today because 052 coils are not MRI compatible. But this is a formula that is available in the chapter I've written in the textbook, which is published by Dr. Hijazi and Dr. Sievert. This combinations are available in that chapter, but otherwise this is what we use pretty much. So anyone has questions at this stage? We can take a few questions and then we can go on to the actual sequence of doing the coil occlusion. Coil, I don't understand. Kshitij, what is it that you are asking? IT of coil 6-8 is. I couldn't understand that. Can you state that question again, Kshitij? Yeah. Length of coil, 6 mm, 6 cm or 8 cm, how to decide? Yeah, it's a very good question, the length of the coil. And I missed out one step. Longer the coils, the more the turns. And again, depends on the ampulla size. So, 6 mm, 5 mm coils, we use 6, essentially when you have the same diameter and the same length, you end up with 3 turns. That is pretty much true for all diameters. So we would generally not try to have anything stick out into the aorta. There are instances where we cut the coil to make sure that it fits into the small ampulla. So the length of the coil really dictates the number of turns that happen. And for a 6 mm coil, we use a 6 centimeter length. And essentially, we use lengths that are similar to the diameters by and large. We don't really need to use very long coils as far as possible. And we can shorten the coils further by cutting the tip, the end of the coil once we've loaded the coil. So that is something that little bit of experience is required, but if you have a very shallow ampulla, you really have to try and minimize the length of the coil. Okay. So the first step is really to get an aortogram, and we don't need to puncture the artery. We obtain an aortogram via the side arm of the sheath, and I'll show you the sequence of that. So this is a aortogram that is obtained in the lateral view, and there are a few important things to recognize. The guide wire is sitting across. The sheath is at the junction of the ampulla with the proximal descending aorta. the injection is made, and because there is retrograde flow across the duct, it naturally flows back and outlines the duct, and you can freeze that frame and obtain the narrowest segment, which is from here to here. The arrows have actually moved a little bit, but it's the narrowest segment which is shown in this particular sequence. Okay, out here. Now I would show you the RAO view. I always obtain as far as possible two views, because if the duct is coming off the shoulder of the aorta, and you will profile it much better in the RAO view. So the RAO view also is a complementary view to the lateral view. This is something I always do, and I think I strongly recommend, particularly if the duct is shallow, ampulla is shallow. Okay, then we take the coils together with the biofilm and pass it so that it starts to oscillate within the aorta. You can see this oscillation. This oscillation is because of the fact that you're actually seeing the coil being pushed in by the pulsatile aortic flows. So this oscillation becomes more subtle as you move towards the ampulla, and once you're in the ampulla, just watch, it stops altogether. It doesn't move at all. It doesn't oscillate at all. And you have the tracheal landmark, you're holding with the biofilm and you release it. So this is a very simple sequence which needs a little bit of practice and guidance, but once you master it, it's really no big deal. I haven't seen really people having persistent difficulty in learning this technique. So I'll just show you this technique once again. You oscillate, but here the movements have to be very slow. You gradually let it fall in the ampulla, your duct is here, and then of course once you're in the ampulla, make sure you will get the resistance, you can compare your images, and then when you're happy, you release it. So that's the sequence. So let's talk about a challenging subset, which is essentially PDA in a preterm infant, because today this is one subset you cannot do with any other interventional technique. You have to do it with the coil technique only. Again, this is very important that you have to do some careful phase selection. You can't pretty much coil every PDA that you see in the preterm age group. You have to send a fair number of them. The majority of them go to surgery because the ducts can be very large. But if you have a duct that is 2.5 to 3 mm and you have an adequate ampulla, and then I think coil occlusion is feasible and can be considered once you're confident of the technique. I know that there is a lot of nervousness because you can't make errors with preterm PDAs, and errors can be very costly. But if you can master the technique with older patients, then it's possible to do the preterm PDAs as well. And there are selected PDAs where the neonatologist will be most thankful if you can avoid surgery. So the first case we did actually had a platelet count of 5,000, and surgery wasn't feasible. The child was septic and they were quite desperate, stuck on ventilator for more than 2 weeks. So we offered the coil, and that's how we sort of developed this technique on preterm infants, and we were able to do a fair number after that. Yes, it's difficult and challenging, but it's definitely got a role in selected cases. So the hardware is essentially a miniaturized version of what I told you with the larger coils, larger patients, older patients. We essentially have everything in a smaller scale. A 4-French sheath. A Cook has a 4-French sheath that is longish, 25 centimeters, and you have a 3-French biofilm that again Cook makes. So you can use that but there are some aspects of technique that really need to be discussed. We get an access with a 24 gauge or a 26 gauge needle. We use a 014 PTCA wire after the access has been obtained in the femoral vein, and then advance the sheath, and through that sheath we put in a wire that comes with a Cook micropuncture sheath. So the access part is very important. Once you get the wire of the Cook micropuncture sheath, it has a very stiff body. Then you can actually take a 4-French shot, the regular introducer sheath after that, and then through that you take a 4-French RCA, JR4, and a 0.25-inch Termo wire which has got a J tip. And the thing is that very important is that we don't manipulate catheters in these tiny babies. Some of our children were very small. The smallest we've done is 850 grams, and what is very important is not to manipulate. So you keep your catheter in the RA, and you manipulate your wire carefully through the duct and go all the way down. So that way you don't put your catheter in the heart and run into the risk of perforation or damage. And then once you've done that, I'll show that sequence again. So you take your curved wire, and just as you would cross, you just use the wire and manipulate it all the way, and it finds its way across the duct. Interestingly, it almost always finds its way across the duct if it's large. Once that is done, then of course the technique is pretty much the same. You remember that the 025 wire is the wire that is supported by the 4 French Cook sheath. It cannot support the 035 wire. So you take that 025 wire, over that you take the Cook 4 French sheath. The same technique you do an angiogram, right just around the ampulla, define the duct, see the extent of the ampulla, see the narrowest portion. Now this is an ideal duct to close in a preterm infection. And then you can actually deliver 2 coils via a 4 French sheath. In this particular case, we've taken 2 5 mm coils and delivered via 4 French sheath. We've had to cut the coil because a full 3 turns of this coil will stick out into the aorta in this child. And so we had to cut the coil and place it very precisely, again using the tracheal landmark. And then before release, we can always do an angiogram to check as to how your coil is sitting vis-a-vis the pulmonary artery. And then once we are happy, we release it. Now interestingly, this angiogram has been obtained. This is very interesting how it has been obtained. In this particular case, we obtained an angiogram because we had femoral arterial, just a cannula inside. And we forcefully injected through that cannula, and in a small baby you can actually fill by reflux. Purpose was not to see residual flow, but to actually show you that the coils were away from the isthmus. So this we often don't do, and we prefer to actually do by echo. We check the situation out by echo, and as soon as we finish, then we have this picture that we actually see that we don't have any residual flow across the PDA. You can see the coil mass inside the ampulla, and then we definitely check for LPA flows. You can see that the LPA flows are unaffected and laminar, and there's an RPA flow that's seen out here, and this is the coil mass that is seen. So this is very important that actually you have echo available, and that way you can completely avoid arterial access in these very tiny babies. This is our first series that we published in JAC Interventions, where we had cases which were relatively small, and we had these essentially a 4 French femoral venous sheath which we used, and then we delivered 1 or 2 5 mm coils. In one case a 6 mm coil, but essentially 5 mm and 4 mm coils that we delivered, and we had a fairly good result in terms of technical success, and the patients also did very well, except for one patient who had a very long hospital stay for other reasons. After this, of course, we've done a few more, and the smallest we've done is 850 grams. So it just goes to show that the technique has its role, very specific role in the preterms. Okay, the complications are very important. So can somebody list out the complications of PDA coil occlusion? Somebody wants to take a shot at what complications can happen after PDA coil occlusion. Everybody knows the most embolization, absolutely. Second, that's something that happens more frequently than devices, because you can make errors with coil sizing. The second one is something that you may not have seen very often, but it's residual flow with hemolysis. Very, very important that we remember these 2 complications. And so embolization can be pulmonary or aortic, and residual flow with hemolysis. These are essentially the only 2 major specific complications of PDA coil occlusion. Infection has been seen subsequently. I've had one patient who's coiled elsewhere who came back with endarthritis because of residual flow and infection at the coil site, which was very, very difficult to manage. So essentially pulmonary embolization. Now this is an example. Okay, how do you want to retrieve this? How would you retrieve this now? If you've had this coil go, entire coil mass go into the left pulmonary artery, and what do you do next? You have to retrieve it, but what do you do with it? Anyone wants to take a guess at that? 2 coils tied together, they come off into the pulmonary artery. Gooseneck snare. So how would you do? So somebody is saying another femoral axis. Ashish is saying another femoral axis. Good idea actually to get another femoral axis, but you don't need it. You don't need it. what would you do? Where will you pass the gooseneck snare? Through a multi-purpose catheter? How would you do it? Okay, let's discuss now. I'll show you some examples. How not to do it first, then I'll show you how to do it. So this is how it was. A coil mass was retrieved in this particular patient, and this is how not to do it. So what went wrong here? So there is potential damage to the tricuspid valve tensor apparatus. The coil is unprotected on its way out throughout the right ventricle. So if you see a cartoon that I have actually drawn to show you that it can actually damage. If you take the same coil mass, this coil mass will get trapped in the tricuspid apparatus and damage the structures as it comes out. So never do it. You can, in fact, the worst thing that can happen is that the coil slips and gets left behind in the right ventricle. So the correct way is to have your sheath go all the way through. In this particular coil mass, we've grabbed it and protected it with the sheath and brought it out. And the important thing is to grab it exactly at that point where you, so this particular case, the coil was retrieved. You have to go grab the end of the coil, and that may look a little difficult, but amazingly we managed to do it almost every single time. So the tip of the coil has to be grabbed, not the entire body, and then you can actually retrieve it. And we've gone to the extent of even using the same coil mass with an additional coil to close this particular duct. So it's not as surmountable. And remember, this is far easier than trying to retrieve an ampulla duct occluder. Pretty much every single time you'll have to end up going to surgery if it embolizes into the pulmonary artery. Okay, let's look at aortic embolization. Okay, this is what has happened in the aorta. What do you do next? Gone into the iliac artery. How do you handle this? So you can actually go back all the way through the duct. You still don't need the arterial access. Go back all the way through the duct, grab the coil in the iliac artery, the way it's been shown out here, and then retrieve it like this. Take it like this. I've shown you the sequence. In this particular case, this is another case. And you can actually deliver it on the way out. And that's what we've done for aortic embolization. And this was 5 or 6 examples that we did. So embolization sounds frightening in the lab, but actually is more easy to deal with than, far more easy to deal with than when you have devices that embolize. And so this is actually, the great thing about coils is that it really is very retrievable. Hemolysis. Hemolysis is a problem that we've sort of stopped encountering for the last 7 or 8 years once we've understood why it happened. The most important thing is that you have to go back and close all the residual flow. You should never leave any residual flow. We've had one instance of we've never had to operate, but there are instances, and there's one child, 1.8 kilos, who continued to hemolyze, and we went in and put in a fair amount of coils in this patient, and it did not occlude, because once you start hemolysis, the duct doesn't clot off. So it becomes a vicious circle. So in this particular child, we did an exchange transfusion, and the patient had a good result eventually. So this is a paper again that was published long ago, 2003, when we used to exclusively use coils to close ducts, and we had 6 instances of bad hemolysis which we have discussed in this particular paper. We've had one instance of very bad hemolysis after a device closure, which happened because there wasn't enough fabric within the device as a manufacturing error, and we went in and actually put coils on top of the device, and that can be done too as well. So, the immediate and long-term follow-up, the overall experience, total experience we've had, this is an old presentation now, close to 2,000 patients. We've had a very good occlusion rate at 24 hours, but the hemolysis, the embolization did happen in the initial years. Now it's about 2.5%. Hemolysis is very rare. There are instances of LPS stenosis if you let your coil stick out. There are instances of late recanalizations, and 4 instances requiring repeat occlusions. So the results have been fairly good actually with coil occlusion. The important thing, of course, is that case selection. We've been very careful to select our patients, and we do use devices far more liberally these days. Limitations very important. Shallow ampulla, you just can't do it. Large ducts, very challenging. Important in today's era is to have MRI compatibility, and that's only limited to 035 and 038 coils and not to 052 coils. It's more expensive than the regular coils, and then I think it takes a little more skill and expertise, but not a lot more. It's easily learned skill, and it's worth doing this than to just try and do devices because that's the easier way out and make the patient spend a whole lot more. Particularly for ADO2, I think where there is an opportunity to do with coils, I think that's certainly worth trying rather than just straight away putting an ADO2 just because it's easier. So to conclude, still very good and inexpensive option for the small and moderate PDA. It's particularly useful in small children. It's the only realistic catheter-based option for preterm. Case selection is important, echo is invaluable, and complications can be more easily managed. So I think at this point, if there are a few more questions, I can take them. Any questions here? Okay, please explain the biofilm method again. I'll do that, and after that we can, what I would want to ask you after that is that if you've looked, after having looked at this presentation, would you then consider coil closure in a slightly larger proportion of patients that you're doing, or would you still stick to your to using devices? So we'll come to this slide again. We'll go slowly in this particular slide. The biofilm method really involves first taking these coils, pushing out half a turn from each of these coils. Now in this case there are 4. Obviously usually there are only 2, and then pulling out each of these coils by a small couple of millimeters, tying all these coils together with the help of a 3-0 proline, couple of knots, cutting off that suture, keeping the knots together, taking a biofilm through a sheath that is 1 French smaller than the long introducer sheath that you put inside the groin all the way across the PDA. Take the biofilm, open the jaws, grab this tip with the biofilm, pulling the entire coil mass into this short sheath and using this short sheath as an introducer for the long sheath that has been placed across the PDA. Then once you've done that, I'll just go through these. Yeah, you perform the angiograms, define the duct, obtain your landmarks, particularly the trachea. Use the lateral view for deployment of coils. Don't use the RAO for coil delivery. RAO is only to understand the ampulla. Then take the coils out, let it come out into the aorta. Maybe a small distance can remain in the sheath. Let it oscillate out here. Don't worry, you're grabbing it with the biofilm. Then bring it slowly back in towards the ampulla. Watch these oscillations as they eventually stop. Here you don't have any oscillations, completely trapped. You've got the same landmark, you're comfortable, you're getting resistance, you've done an angiogram, you can release it. So is that clear, Kshitij? So now the question is, the only question I'd like to ask you guys is that would you consider using coils in a slightly larger proportion than you're currently doing, or do you think that there is more scope for coil occlusion? You cut it with a large scissor. Essentially, you withdraw the coil mass. I'll show you that same sequence which we had out here. Okay, so in this particular coil turn, you've got out these coil turns. You've pulled the whole coil mass into the sheath. You've got out these coil turns, and you feel that this much is excessive. You have enough inside which you think is adequate. You can just simply cut it off with a relatively solid, heavy scissor. not a small one, and make sure after you cut the three edges are smooth. So that's how you cut it. I mean, it's a very simple, straightforward thing. Not to worry. You don't need anything more than just a very good scissor. So you cut it, and then you make sure that the tip, once the tip is cut, the tip should not have, you know, the metal sort of sticking out like that. And usually you can cut it very flush, and that's good enough. Okay, I'll wind up now, and thank you for your attention.